Good evening and welcome to our webinar with Dr. Mary Dingley. Tonight she'll be discussing her clinical experience with PicoWay and Vbeam. If you'd like to submit a question, please use the Q&A function of this WebEx, and Dr. Dingley will answer questions at the end of her webinar. I'll now pass you over to Dr. Dingley.
Thanks, Mike. I hope you can all hear me, and for those who are attending live, happy Star Wars Day. So we're going to talk today about the PicoWay and the Vbeam. I'll go through the Vbeam first of all, which is a primarily vascular laser, but it does have some other things that it can do as well. So if we have the first slide, please. I must apologise, I don't have my hands working on this sort of presentation at the moment because we found that when we loaded things up, all the videos and slides didn't progress terribly well. So I'm having to rely on a very capable Dingley to move things for me. So apologies if we're not quite as well coordinated as we would otherwise be. Now, Candela have been doing Vbeam lasers for quite some time, and prior to that, some other vascular lasers in the same sort of line. And prior to this millennium, I was using a different kind of vascular laser, but I started using the Vbeam technology well, in the noughties, basically, in the early 2000s. And I've actually progressed through all three of the Vbeams and currently have the Vbeam Prima. So starting with the Vbeam Classic, then the Vbeam Perfector, which was a development of the original Vbeam that divided the original pulse into 8 micropulses, which meant that you could do more without actually getting quite so much of the purpura. And the Vbeam Prima, which is the latest innovation in the Vbeam technology, which has the 595 nanometer laser that we're all very used to, and has the addition of the 1064, as well as 2 different kinds of cooling. Next slide, please. Next slide. Thanks, Angie. Okay, so looking through the features of the new Vbeam Prima, which we've had for a couple of years now, we have, as I said, the 2 different wavelengths. So the 595, which is the classic wavelength that we use for vascular technologies, as well as the 1064, which enables us to get a little bit deeper into the skin and even to the subcutaneous tissue, and to do more of the larger veins and the deeper sorts of blue type vascular defects that we might come across. And we have 2 different kinds of cooling. So we have the dynamic cooling device, which is the spray that hits the surface of the skin and gives a very intense cooling to the epidermis, so that when we fire the 595 or whatever subsequent to that, the epidermis is very, very well protected by this. And we also have the contact cooling, which basically enables the cooling to get a little bit deeper down into the dermis. So it's not that instantaneous sort of cooling, it's more a prolonged cooling, which is not as intense, but can give a little bit more efficacy for some of the deeper types of laser treatments that we might do. So for something like leg veins, which I really don't do terribly much of, but some people do, probably do your sclerotherapy or whatever first of all to get the really big veins. But then if you've got a few small reticular veins, you may want to use the 1064 to reach some of those. And you probably are aware that some of the previous technologies from other companies, if they didn't have the cooling which lasted even after the pulse of the laser, the heat from those veins which had been coagulated would then spread from those veins and could actually burn the skin. So there are a few leg scars around which have come from laser technology which didn't have adequate cooling for those sorts of indications. Now the Vbeam Prima also has a larger spot size. So instead of just the 10mm spot size which we had previously, and 12 which we really used terribly much on the previous Vbeam Perfector, we now can go up to a 15mm spot size, which I would primarily tend to use on things like porphyroderma of the neck and décolletage regions. So you can get through treatments a lot more quickly with the larger spot size. as well as get slightly more effective transmission to some of the deeper tissues, as we all know, from using a larger spot size for anything. We also do have a lot more oomph in the laser with the vBeam Prima, so that we can actually get a lot greater fluence for whatever we're trying to treat. The smart dye life management really just means that it's a lot more effective in using the dye that we do use in the vBeam. So we don't have to change and have a dye kit replaced quite as frequently as we did with the previous technologies. It's basically just a more efficient use of what we had before. Also, one of the bugbears, I guess, of the previous vBeams that we had was every time you changed the parameters, you had to recalibrate, which was no big deal. It's just what we all did. But now we can just sort of calibrate at the start of the day. And generally speaking, unless you're changing anything or leaving it for a very, very long time, not having been used, you can just still use it each time without having to recalibrate, which is just a time-saving feature, basically. We also have a zoom handpiece, so you can basically just change the flywheel and change the settings without actually having to change the sliders as we had to previously, which again just saves some time during procedures. And also the techies can now get on board to the machines and actually do a bit of diagnosis rather than having to rely on phone calls quite so much, and they can actually have a look and see what is happening with the lasers without having to come on site, or at least be a lot more prepared when they do come on site for what they may have to do to service our lasers. And of course, we have a touch screen now, which is just a really easy to use type of technology. Next slide, please. Okay, so as we all know, the 595 is the gold standard for oxyhemoglobin. So the shorter wavelengths that have been used in some of the technologies for vascular lasers often don't penetrate as well into the skin as the 595 does. And it often does tend to get absorbed a lot more in the melanin, which is in the skin as well. So there's a lot more competition with some of the shorter wavelengths. And the longer wavelengths obviously don't absorb so well within the hemoglobin. So the 595 is one of those Goldilocks type parameters that we can use so that it gets that little bit deeper down into the skin, and also just sort of goes into the vessels that little bit more rather than just being absorbed right on the surface. So you can get some slightly larger vessels and coagulate them more completely through the whole of the vessel without having as much competition with the melanin in the skin surface. Next slide, please. Next slide, Lindsay. Okay, so the two different types of cooling that we have with the vBeam Prima is the dynamic cooling device, which we had on the previous vBeams as well. So we have a short burst of fluorocarbon before the pulse of the 595, or 264 as well in this case, and it supremely chills the epidermis of the skin so that you are protecting the epidermis from the heat which will be applied when the laser meets its target. So this will actually very, very efficiently chill the surface of the skin, the epidermis. The contact cooling is not as cold, so it's actually not as efficient as at protecting the epidermis, but it can last longer and it can also get deeper down into the dermis. So as I was saying before, when you have some of those deeper, larger structures and you want that cooling to stay for longer after your pulse, the contact cooling is very good at protecting the epidermis and protecting the skin from those burns I was telling you about with things like lead veins. Slide, please. Okay, so we have the micropulse technology, which basically allows you to add up the fluids that you're applying to your target without reaching that per threshold. So instead of getting this sort of bruising, which you might get very easily if you just had one pulse, or some pulses which were very variable in terms of their energy application, with this sort of 8 micropulse technology, which can all be below the purpura threshold, you're less likely to get purpura if you're not targeting to get it. Now, of course, there are still some things that we do need or want to get purpura in order to treat, like your port wine stains and things like that. If you're not getting the purpura, you're not really going to get an adequate sort of treatment for those particular indications. However, your regular run-of-the-mill sort of thing that you treat regularly every day, like facial telangiectasia, you really don't want purpura for these sorts of things, because people want to go back to work, they want to put on their makeup and get back into life without having substantial bruising on their faces or wherever their indication is. So the sort of everyday things that we treat, like the porculains, like the facial telangiectasias, you can do without getting purpura, whereas the things like the port wine stains and so on, you really do need to get the purpura in order to treat those terribly efficiently. But most people have already got a mark on their face with those sorts of things, so obviously if you explain to them that it is going to get bruised afterwards, they can usually accept that fairly well. And they usually are already applying some kind of camouflage to disguise that sort of thing, so it's not so much of an inhibition on their lifestyle. Next slide. So just comparing the three generations of the VBEAM, if we look at the grey column on the right, and we can just sort of flip back to what we didn't have before. Yes, we have the 595, we've always had that in all the VBEAMs, but we now have the 1064, which enables us to get that little bit deeper down, to do things like venous lakes on the lips, which I used to go to radio frequency to treat those prior to getting lips. Now I can just use it on the one machine. We have the 8 micropulses, which we also have on the VBEAM Perfector, but it's probably a little bit more refined now. We have the largest spot size, up to 15, which, as I said, I would tend to use mainly on the neck and décolletage, rather than on the face. I just find that the sort of maybe the 12 millimetre or 11 millimetre or something is quite fine for the face. We do have more energy available so that we can treat things more efficiently with a greater fluence at a bigger spot size without having to hone down the spot size in order to get the effective fluence. We have the smart dye life management, which basically means that we don't have to change dye kits quite so frequently, and it's a more efficient use of the dye kits that we do have. One-time calibration rather than calibrating every time we change parameters, which makes the treatments a lot more efficient and user-friendly for us. We have the 2 different cooling options, which I explained before. We have the dynamic cooling device with the fluorocarbon spray, which gives you very efficient surface cooling instantaneously. And then we have contact cooling, which we tend to use for the deeper structures that we need more of the long-term deeper cooling. Zoom handpiece, so we have that flywheel that we can change the parameters very easily during treatments. The distance gauges that we have, we do tend to change some of the distance gauges. Although we have the Zoom flywheel, we do often have to still change the distance gauge, which tends to then make sure that we're getting the right dynamic cooling for that spot size. So you'll see in some videos later on that the spot size that you see may actually be within the distance gauge that you have rather than the same size which you may have seen with the VBEAM Perfector previously. And the remote connectivity just means that it's easier for the techies to see what's going on with their machines before they arrive on site. And the next slide, please. And next slide. So going on to what we can use the VBEAM Premier for, and there's one big thing that I would like to add to this, which we'll get on to in a moment. So of course we have all our red vascular abnormalities, the facial telangiectasia, which is your bread and butter, which you're going to do every day with this machine, and maybe some hemangiomas, neurangiomas, cherry angiomas, spider angiomas, and those sorts of things, as well as the venous lakes and so on, which you may have more in the blue spectrum, and that will be more with the 1064. But with your 595, your facial telangiectasia you're doing every day. Your port wine stains you will probably get periodically if you're in a medical practice. Your rosacea, certainly for the redness of that and the blood vessels occurring for this rose, your porphyroderma for that on your neck and decolletage areas. And obviously that's a red, but sometimes also a brown sort of thing. And if you help the red, the brown often subsides along with it without actually having to really target that. But occasionally you may also need to target the brown. But I usually go with the red first of all because the brown tends to settle along with it in many cases. I personally don't tend to use the Vbeam terribly much for benign pigmented lesions because I have other machines that do that, including the PicoWay, which we'll talk about a little bit later. Getting on to the blue side of the spectrum, as I said, I don't tend to do much of the leg veins. Some of you may do that. I tend to send them off to a sclerotherapist so that they can do the ultrasound-guided sclerotherapy or whatever is needed first of all. Sometimes they will send them back to me after they've cleared a lot of those and I can work with laser and the residual veins if needed. The venous lakes, as I said, I used to do them as radiofrequency, and now I don't need to do that. I can do them all on my Vbeam. Wrinkles, I tend to find do improve coincidentally. I don't tend to target them so much with this machine because I have other pieces of equipment which can deal with those probably more effectively. But yes, many people do find that they get textural improvement along with their treatments for their rosacea, their telangiectasia, or whatever we're treating along the way. Certainly we do use it quite frequently for people with acne, especially if they do have an inflammatory acne or if they have acne scarring, which has a lot of redness. And we do find that a lot of the colour along with that will tend to subside with it. And of course, we can use our intense pulse lights and other treatments, including the PicoWay for acne scarring if it doesn't have so much in the way of colour. Yes, I do use it quite a bit for warts and scars. Probably tend to use other things for stringy unless it is more coloured in terms of being not so much the alga but more the rosa. And psoriasis is not something that I tend to get asked about terribly much. They would tend to go more to the dermatologist for that. So it's pretty rude, I can see that erosion with my good connotations with that. Next slide, please. So just looking at a video here, so if you could play that video for me, Lindsay. And I'm sorry, I do find that the resolution on this does tend to reduce. It's a very good video taken by a TV cameraman, and I'm sorry if it doesn't sort of show quite so well. Now, for me, that's still black, Lindsay. Can you play that? Basically, what it will show is just me doing test spots initially. So you do one zap, and the patients always will tend to flinch at that, and it's mainly from the spray, actual dynamic cooling device, which tends to make them flinch. For me, that's still not playing in the machine. I'm not sure what's going on there. Would you try it again, maybe? I do apologise, everybody. We went to a lot of trouble to see that these were all working before, but obviously it's not working at the moment. But basically what you do during treatment is you do one zap, and you tend to see that you get a momentary mild purpura which dissipates within a second or two. And then you know you're at the right distance for what you're trying to achieve. And then you can sort of carry on. It's just a zap, zap, zap going over the area. Okay, so someone tells me it's playing their end, so that's good. Okay. So hopefully you did see that. But basically you're going over the area, and I tend to explain it as feeling like a bit of a flicky skin for the patients. And I expect them to flinch and all of that sort of thing. And most people are quite fine with it, but it is not a pleasant sensation. So you do need to explain to people that they are going to feel something, but it is momentary and it does not hurt afterwards. And they will tend to look a bit flushed immediately afterwards, and very occasionally some people do get a bit of swelling, which is a temporary thing which will go. So you can play the next video as well from YouTube, which is just on the nose. Okay, so again, that's not playing for me, and I hope it's playing for you guys at home. So the vessels on the nose are that little bit bigger, and I'm sorry if they're not showing up terribly well on the nose because the resolution in these videos was very good when we took them, but not so good on this platform. But with the vessels on the nose, you tend to have a slightly longer pulse duration and a slightly higher fluence to treat them. And what you should see is the vessels basically disappearing. You have a momentary sort of purpura over the area, and the vessel basically just goes into spasm and it disappears at the time. And you need to tell people that the vessel may look as if it's returning as the spasm relaxes, and then the bodies will then work on reabsorbing over the subsequent 6 weeks. And you tend to plan treatments maybe 6 weeks or so apart. Okay, so if we can go to the next slide. Okay, so this is the other indication that I was talking about before, and this is a bruise. This bruise is actually on the buttocks. So this was actually my then practice manager who'd been to see a show, like a musical theatre or something like that. And she'd got up at the end to clap mad because she thought it was such a great show. And then she forgot that the seat bottom would flip up as soon as she stood up, and then went to sit down and totally missed the seat and ended up well, on her bottom basically, and she ended up with this huge bruise as you see on the left. So she asked me whether I could do anything to get rid of the bruise. I said, sure, let's hit it with the V-beam. So 2 days later, you can see that it has quite an amazing clearance of the bruise. But it's got this rim around the outside. And what was basically happening is that bruise was still expanding in area, so that you end up with this rim around the outside. As you can see, the circles that have cleared around the outside of the photo on the right, those are actually pulses that I did outside of the area of the bruise that you see on the left. So it was actually still clearing on this, but that bruise, that the rim around the outside was not actually there 2 days previously. But she was actually much happier with how it felt as well as how it looked, and she could see that it was going. So we didn't actually need to do anything further at that stage. But I think it shows very, very clearly how it can get really bruising. And what we tend to use this most frequently for is for post-injection bruises on the face. And I tell all my patients for fillers or whatever, that if they do get a bruise that is problematic for them, they can't cover it with makeup or whatever, to come back and we will run the laser over it. And it doesn't clear instantaneously, but usually even by the very next day, the bruise has been very much reduced in appearance. And it's also a useful thing to tell people, just in case you've got one of those people, which touch wood I've never had, who has an ischemic event and they can't tell the difference between a bruise and an ischemic event, then they will show up on your doorstep saying, I have a bruise. You can look at them and say, that's not a bruise. Let's put some hyaluronidase into that. But as I say, touch wood, that hasn't happened as yet, and they have all the bruises that we have just been able to run the V-beam over and improve people's lives very quickly and easily with the use of that. Next slide, please. Okay, now this is actually a case of hereditary hemorrhagic telangiectasia. So this lady has telangiectasia and little angiomas over much of her body, including internally. So she was most concerned about the angioma in her nasolabial fold, but also the telangiectasia on her cheek. And we used the 1064 on that nasolabial angioma and the 595 for the other telangiectasia, and she will continue to get these, and she's even had some on her tongue that we have done for her, and basically whatever we can reach, we can give them as that and improve her life for her, because a lot of these do actually bleed, not so much of the sort of telangiectasia on her face, but some of the ones on her tongue. We can't really reach the ones in her nose. Unfortunately for her, that she's had a lot of relief from the ones on her tongue, which were quite problematic for her as well. Next slide, please. So this is a port wine stain, and this is just one treatment from left to right. Now, she had some deeper vessels, which you can probably see some of the larger vessels in the left-sided slide. So we did the 1064 and then followed up with the 595 straight away to reduce that. And next slide. She's had 2 more treatments with the 595. So the one on the left is before we did anything. She had actually had some treatments earlier in life with a laser. I'm not sure which type she wasn't aware which type, but it had actually given her a little bit of scarring, which has made her eyebrow a little bit straight in that area. But as the vascular nature of what is residual is going away, she's finding life a lot more easier and much easier for her to put on her makeup and carry on as well. Next slide, thank you. So now we're getting on to the PicoWay, which is our picosecond laser from Candela. So next slide, please. Thank you. So this is a pure picosecond laser, and we currently have 3 wavelengths with this. I've had this for a number of years now. So originally when we had it, we had just the 1064 and the 532, and we were waiting for the 785. And it will actually have another wavelength, which is a 730 nanometer coming, as well as another handpiece, which gives us a different form of beam, of the fusion beam, which for those who have the core CO2 laser, you'll be familiar with the fusion, which has this sort of central beam and a ring around the outside. But we don't have that as yet in Australia. Some of you in Hong Kong may have had some experience with it, but we have not as yet. So with this, we can do the traditional, if you like, picosecond full beam coverage type of treatments, as well as the fraction treatments, which is called resolve in this case. So we can treat many different colours of tattoos. Obviously, we'll be able to treat some of the greens and blues even more efficiently, as well as using the 785, also the 730 when that becomes available. Still, we have the precaution that we say whenever you have white tattoo or some of the cosmetic tattoos, such as the lip liner tattoos and so on, or the skin color tattoos, if you treat these with any kind of Q-switch laser or picosecond laser, you will have darkening of those tattoos. So you may want to use some other kind of treatment for those, or at least warn the patient they will have that paradoxical darkening of those tattoos if they are treated with these types of lasers. Yes, we can also treat pigment lesions, which we'll get onto a little bit later, and it also does tend to improve skin texture, more so, I think, than the Vbeam does. Next slide, please. Okay, so here we're also mentioning the 730 nanometer wavelength, which is the next one to come. So we will have 4 picosecond wavelengths. And you've probably had some marketing from some other companies that sort of say that we should still keep the nanosecond and then progress to the picosecond. I think that sounds quite convincing, but honestly, I have no evidence myself with using picosecond lasers that is necessary in any way whatsoever. So I'm very happy just to start with any new tattoo with the picosecond wavelength, and I certainly don't think that I've lost anything by starting with the pure picosecond lasers. Of all the lasers that are picosecond lasers, it has the highest peak power, as you've probably heard from other presentations, and the shortest pulse durations. And of course, we can change the spot sizes to what we want to achieve. So we have the zoom lens, which you can change the spot size by just sort of twisting the dial on the actual handpiece itself, and you'll see that change reflected in the the interface on the laser that you can see what the spot size is. With the 785, you do need to change the handpiece, and it has just the 2, 3, and 4 millimeter sizing that you can use with that and spot sizes. Then we also have the resolve, which you use the 532 and 1064, which is the fractionated beam, which you see on some videos shortly. So you have a 6 by 6 millimeter square, which it will cover, and it has 101 spots within that 6 millimeter square spot. Well, you know what I mean. And you have 2 different handpieces along with that, the 1064 and the 532. And then, as I said, coming, there will be another handpiece, which is the fusion handpiece, which will be the 532. So next slide, please. So we've seen some of this also with some of the previous presentations that we've had, including the very nice presentation that Dingley gave not so long ago. So with the biopsy of the skin, when you do the resolved treatments, what you'll get is these cavitations between the dermis. So you've probably heard of the term laser-induced optical breakdown or laser-induced cavitation. So you have this sort of gap made within the dermis or the epidermis, depending on the parameters, which will then fill in with collagen stimulation over time. So you do tend to get this dermal remodeling, which improves the skin texture, but also does tend to help with things like melasma and some of the melanin type problems that we have in the dermis. So, next slide, Lingji. Okay, so this is just a diagrammatic representation of the holographic beam slitter, which gives us those 101 spots which we're talking about. And in the photo on the right, you'll see those little dots. So there's 10 by 10 and then one in the middle. So it's 101 spots, a little bit of reflection which you see around the outside. And that gives us a very, very even amount of energy in those spots. So you can really be sure that you're not getting hot spots and cold spots within that 10 by 10 array. Which basically means that you're not tending to get like over and under treatment in various areas, and especially the over treatment if you're going to be treating things like melasma, in especially Asian type skins, because they do tend to be more prone to the post-inflammatory hyperpigmentation if they are treated at too high levels. Okay, so just looking at some of the studies which have been used mainly for FDA accreditation. So for wrinkles, basically it's very good for that. You can use it quite gently over the whole surface of the face. Whether you use MR or topical anesthesia beforehand, we tend to do it as a default, but not everybody wants it or needs it. And we'll go over the face with a number of different settings. So when we use the resolve handpieces, it sort of is a little bit counterintuitive in that the lower settings will actually penetrate more deeply into the dermis. So we tend to start with a low setting and then work our way up through the dermis with a higher setting. So we're actually treating multiple layers within the dermis. And that can produce a quite intense remodeling of the skin. Next slide, please. Okay, and likewise with the acne scars, because they are going through all the layers of the skin, if we can reach those multiple different layers within the dermis, we can have that very intense remodeling so that we can get a good improvement in the overall texture of the skin without actually just relying on the very surface. With many of the lasers that we might otherwise use, we can sometimes be a little bit limited in terms of what we use because we may be inducing post-inflammatory hyperpigmentation, whereas we don't tend to get that so much with the PicoWay, especially if we're sticking with the 1064. Once we start using the 532, we need to be a little bit careful, especially with Asian skins and those types of skins that are a little bit more prone to the PIH. And we tend to use just the very, very low settings. So we're going deep down in the dermis rather than more superficially. With the 1064, you can be a little bit more, you can use it at multiple different levels, a lot more easily. Next slide, please. Okay, so for most people, it's quite a quick treatment. Okay, as I said, by default, we tend to use topical anesthesia for most people. However, not everybody does need it. And it's something that I can delegate reasonably easily to my nursing staff. I write all the settings down for them and they follow those. And we generally use a Zimmer cooler, which blows cold air as well. We do tend to look a bit flushed immediately afterwards. Occasionally, some people will get a little bit of like a hive-like temporary response. Very few people do, but occasionally some people will, and some people will occasionally get some acne-form lesions, all of which tend to resolve quite easily and quickly. Next slide, please. Okay, so getting to the tattoos. So I'm sure you've all seen this many times before, where the nanosecond lasers will reduce the tattoo particles to a certain size, whereas the picosecond lasers tend to reduce it to a much smaller size, which is then more easily cleared by the macrophages in the skin. So as I said before, there are some companies who will say that they start off with the nanosecond and then progress to the picosecond, and I haven't found that to be necessary. So I'm quite happy to start with the picosecond and just progress with that. Next slide, please. So this is just firing the laser at vials of tattoo ink. And as you can see with the shorter picosecond laser beams, we can get to a lot more clearance of the ink and the colour in the ink with the same number of pulses. Next slide, please. Okay, so here we have a video again, so if you could play that first mention. And I have put some local anaesthetic in for this, and once again, I can't actually see this video, so I hope you guys can. So I generally do put local anaesthetic in for most of my tattoos, except if patients have requested that they don't. Some like to have anaesthetic cream on beforehand, and others just do it with nothing. And by default, I tend to use this holding with my right hand on the handpiece and then actually moving it with my left, and I find that that is a very stable way to follow over a tattoo. And you do tend to get this bit of frosting, which I hope you can see. This is not the first time this tattoo has been treated, so you won't get as intense a frosting as you will with the first time tattoo, but you still will get some. You tend to get less and less of that with subsequent treatments of the same tattoo. Next slide, please, Angie. Okay, now this is a tattoo which belongs to a professional boxer, and his girlfriend wanted him to have this tattoo, and then they broke up and he didn't want to have the tattoo anymore. But he was quite amenable to my using his pictures and also doing a study on him. And as you may be aware, the PicoWay is not the first picosecond laser to the market, and I did actually have a different picosecond laser before the PicoWay arrived, and quite frankly, I wasn't very happy with it. So I wanted to prove that it was not that effective a laser, so I used it on the anterior half of this tattoo, and I used the PicoWay on the posterior half of this tattoo. And the middle picture is after one treatment, and you can already see that there is a difference between the anterior and posterior halves of this tattoo. And then we kept going with treatments, and you can certainly see the PicoWay posterior half is progressing a lot more quickly than the anterior half of this tattoo. Now, with any of these sort of comparisons, you can, if you want to do this, arrange things so that the fluences that you use are ineffective on the side that you want to go more slowly. And I have to say that I did not want to be ever accused of anything like that. So if anything, I erred on being stronger for that particular laser on the anterior part and softer, if anything, in the posterior half. But still, the PicoWay was much faster in this case. And of course, they were different wavelengths, but that company that had the original laser was quite adamant that wavelength didn't make much difference at picosecond pulse durations, and I don't think they were correct. Next slide, please. Okay, so this is just to show one treatment on a really blue tattoo, and you see a lot of that, or most of it has been used in one treatment, and then we can progress to using the 1064 or so on the black, a little bit of residual blue-green, which we can also treat with the 795. Next slide, please. Okay, so for pigmented lesions, this is a very good laser for this, using either your 532 or your 1064, depending on the depth of the pigment that we're going to use, and also on the skin type of the patient. So for those where you've got your seborrheic keratosis and tigenes, you're going to be using 532. If you're going for your mucosal and those deeper type dermal pigments, you're going to be using your 1064. You can still get PIH if you get a lot of inflammation, so therefore you often just have to think about the fluences that you're using with those particular skin types that you're treating. Next slide, please. Okay, so this is a girl who is very fair. She has mainly pheomelanin freckles, and she absolutely hates them. She's quite a young girl, so I didn't want to do a terribly severe treatment on her. So we started off with intense pulse light, which would also tend to help a little bit with her acne. So the middle picture that you see there is after one intense pulse light treatment. So IPL is the IPL that we have is not that effective on pheomelanin, and I told her that beforehand she'd have some reduction in her freckles, but they did not grow. And she said, okay, we'll try that, and she'd see what she would think about that. Having had one treatment, she said, no, I want to go up to the PicoWay. I want to do like Nicole Kidman did and get rid of my freckles. So we did that using the 532 at 1 G per square centimetre over the whole of her face, and basically her freckles have gone. And now we can start working on her acne as well. So this photo, the one on the right, is after 1 week. So you can see she still has a little bit of residual pinkness there, but you can also see her skin texture apart from her pimples is looking a lot smoother as well, and she's very happy with the result. That degree of treatment is not a pleasant treatment for people. They do have downtime with that. They will have swelling, and they will tend to look a little bit like they've done a face plant off their bicycle. But it does work very, very effectively for those pheomelanin type freckles. Next slide, please. And we have quite a few of these patients in Australia who are very fair and have these pale freckles. So this is another lady who's basically done her arms, and we've done her face, we've done her arms, and I have another patient where we've actually done her legs and buttocks and everything like that, but in segments, because it's a little bit too much to do such a big treatment on huge areas of the body, and it is quite a bit to get through. But certainly on the body, it's a little bit easier to cope with the aftermath, although it does take a little bit longer to settle down. Next slide, please. Getting on to what most people are probably aware of the PicoWay doing is for our Asian patients, especially for the melasma and some of the big presentations such as Hoisman's and and so on. So the melasma that we see in Australia, and certainly in Queensland where I am, does tend to be a little bit more problematic than the melasma in Asians in Asia. So I do have a lot of my Asian patients who say that they didn't have problems with their skin when they were in Asia, but when they came to Australia, that's when the melasma and other problems started. If they go back for a while, it resolves, and if they come back to Australia, it comes back again. And there does certainly seem to be something different about the sun in Australia, especially in Queensland. I generally don't start with the PicoWay. I will start with topical treatments, like a tretinoin, hydroquinone, dexamethasone, cream, and see how they go with that. Because whatever we do, including with lasers, these sorts of things like melasma do tend to return, so it does tend to be an ongoing treatment and therefore can become expensive. So you can see it's done quite a good job here of the Hoisman's as well as the melasma. And often, even when these patients have had their pigmentation resolved, they do actually keep coming because they like the way their skin texture also improves with the treatment. Next slide, please. And another one of my very pretty little Asian patients, and she's an adorable little girl, she has the same sort of problem as well. The redness that you see in the right-hand picture is due to some topical anesthetic cream because she's continuing to come for skin texture issues. Strangely enough, she's not actually concerned about pigment on her forehead, it's only in her cheeks. So that's all we treat on her, is her cheeks and her nose. Slide. So getting onto a video, if we could play this one as well, thanks, Minji. So this is a half Asian, half Eastern European chap. He has a type 3+, so the 3 to 4 type skin. So he has some seborrheic keratoses and lentigines, which we're treating with 532. And again, I apologise, I can't actually see this video playing, so I hope it's playing for you. And you'll see a little bit of frosting on someone who was more Asian than this chap. You might even want a little bit less frosting than that to avoid post-inflammatory hyperpigmentation. But purely for the sake of seeing how it looks, is you get that minimal frosting over the actual lesions that you see. And then once we've done the lesions, you see if I start just going over the area, and I'm not sure where you are in the video, but you see that the red large spot size just moving over the whole of the surface of this cheek. And so we start off with the 532 at a relatively low fluence, and then we're progressing to 1064 at a large spot size of 8 millimeters and a low fluence of 0.8 juice per square centimeter. And going over the whole surface just to stimulate collagen remodeling and improve the surface of the skin. So unfortunately with the 1064, you're not going to actually see when the laser's firing and not, so it looks a bit boring. I'm sorry, it's just the dot going over the surface, and that's just the aiming beam. It's not actually the laser firing, so you're actually more on firing and not firing. Whereas when you do the 532, you probably appreciate some green flashes. So I think we should be getting towards the video. So I'm sorry, I can't actually see the video, so I'm not actually sure what we're up to. He has had some topical anaesthetic on beforehand, but he does actually find the treatment quite comfortable. He's actually one of these patients that thinks I saved him from a fake recent death because he had quite a bad car accident. He had a lot of scarring over his face, which you might actually have seen in some of his videos in doing the 1064. So he's one of these patients who's always very happy to volunteer for any videos that we might make. Next slide, please. And this is another video, if you could play that. Now, this is a lady, she's a type 1 skin. Actually, she's the same lady that we used for the 595 Vbeam videos earlier on. And so you'll see that with this 532 setting, we're getting a lot more intense frosting over the spots that we're doing. So I'm using a higher setting here because we're not so concerned in this patient about post-inflammatory hyperpigmentation. We're more concerned about efficacy. So the setting I'm using, I think, is at 1 joule per square centimetre going over these areas. So with this, you get the intense frosting and you'll get some crusting of those lesions, and they'll flake off usually over a week or two. There may be a little bit of pinkness residual on that, but because she is a fair person, she is less likely to get the post-inflammatory hyperpigmentation, and she'll keep up her sunscreen. Again, she's another one of these patients that thinks I'd say for less than that, so she's happy to volunteer for these sorts of treatments as well. But she's been very, very happy with the resolution of those spots on her hand. And I think we should be just about at the end of that video. Hopefully. Okay, so if we can go to the next slide. So this is the same lady again, and this is another video to show the result. So if you could play that video, thanks, Lindsay. So this is the same sort of thing that you could do on the face of that chap that we did before. And this is, again, producing that skin remodeling. Now, this lady's got some very bad scars on her legs from some trauma and infection that she had. And she's got some post-inflammatory hyperpigmentation around those scars. And I think you might be able to see as we go over it, she's got some little island cells within the scars. So it's not totally devoid of normal skin cells in that area. But she wants to try and reduce the PIH around those scars. So reducing that skin remodeling to promote smoother area as well, and try to remodel some of the scar tissue. But they're also going to try and reduce some of the post-inflammatory hyperpigmentation. And because she is fair, we can actually use the 532 resolve at quite a high setting on her, which we'll get to with the next video. So with this, we're doing the 1064, starting off with the low setting and then moving up to a higher setting as we're going through the different layers of the skin to produce that more intense remodeling of the skin to make it smoother and include the scar tissue better over time. So hopefully we're getting towards the end of that video, and then we can move on to the next one. Let's see if we can move on to the next one. Okay, so if we could play that one as well. Thanks, Nancy. So this is just a very short video, and this is using the 532 resolve at a relatively high force. So you'll see at the end of this, you can actually see the white dots. Now, you do not want to see that if you're treating an Asian person or someone with a darker skin type. Because she's fair, we can do that, and that will actually create the dots which will flake away, and they'll look a little bit more like a fractal treatment or whatever. You see those white dots? That's in the epidermis itself, and that flakes away. It does actually take a lot more of the pigment, which is superficial, away as well. It also does tend to create a little bit more erythema, which you can see in that area as well. Next slide. Next slide, thanks, Lindsay. So this is, again, before and after. Now, this is a type 5 skinned young boy who had a cafe au lait muscle on his upper thigh, and he was quite happy after one treatment. It's still a bit pink at this stage, but that has continued to resolve, and we didn't need any more treatment at this point in time. As you're probably aware, cafe au lait muscles can occur, and I wouldn't be surprised if it does return for some more treatment in the future. But at this stage, he didn't need any further treatment. And next slide, thank you. Another cafe au lait macule, this time on the base. And this hasn't totally gone with one treatment, but it has dramatically reduced. And we did do a little bit more in her. and we'll probably see her maybe in another 5 years or something. I saw her originally, I think it was about 5-year intervals between treatments for her. And next slide. Okay, and we did go through a period where one of the hospitals had a rash, if I can say that, of iron stains after some iron infusions tissued and created quite a few patients that came along to see me for these sorts of things. And we treated this with the 1064, not resolved with the picosecond zoom lens handpiece. And we do get quite a good resolution of those sorts of things as well. So these are two different cases. The one at the top is before and after just one treatment, and the first period before that. The second one was a little bit more intense, and the after follow was after 2 treatments, and we carried on a little bit further with that. But they do resolve quite well. The hospital now has changed its protocol, so hopefully we don't have too many more of those, but they realise if they do have that sort of issue, that at least they've got someone they can call on to treat those to avoid a lawsuit. Okay. I think that's it actually. So next slide. Thanks, Nancy. Yes. Okay, here we are. Sorry, we have got a little bit of time. And do we have some questions?
Thank you, Dr. Dingley. We do have some questions. I will pass over to India. She'll read out the questions that have been sent through.
The first question is, as mentioned, paradoxical darkening will occur during cosmetic ink removal. What is your protocol for further treatment?
If it has darkened?
Yes.
Okay. So basically, first of all, you can try and avoid it by using a different kind of treatment. And I do quite frequently use the deep setting on the core laser to reduce the amount of ink that is there without having the paradoxical darkening. However, if you do get paradoxical darkening, then basically just continue to treat like a black tattoo with the 1064. It is harder to remove than a regular black tattoo, so you just need to tell people that. And certainly some will take an awful lot of treatments. I did have one lady who had the most ridiculous lip tattoo, which sort of ended up halfway between her vermilion border and her nose. And she did want it removed, and she was happy to have the paradoxical darkening, and we did it. And it probably took us sort of 8 to 10 treatments, I think, to totally remove it. A lot of it did remove in half a dozen treatments, but often you'll have a few little dots, like where the tattoo has just gone a little bit more heavily in certain areas to remove it. And unfortunately, she did actually have scarring, not from the tattoo removal, but from the tattoo itself. So subsequently, we did have to work on the scarring itself. But yes, it's a difficult problem, so avoid it if you can.
In your medical experience, how does the PDL work in combination with the PicoWay for melasma? Have you had greater response rates from this combination, and what would your suggested protocols be?
With some people I have, and there are some people where if you look at their melasma and you can see that it's a telangiectatic melasma, you can actually see blood vessels. I will generally do the pulse dye laser first, and often you will find that some of the pigmentation, the melasma, will actually resolve along with the vascularity. And if it doesn't resolve completely, then you can go to the PicoWay subsequently. So I generally go pulse dye laser first and then PicoWay second. However, if I really can't see any evidence whatsoever of vascularity, I generally don't go with the pulse dye laser first, because I find that it just doesn't seem to have that much effect.
And for the last question, when will you and how will you combine the core for tattoo removal?
Okay, well, as I mentioned before, if I'm talking about a risk of paradoxical darkening, I'll generally opt for the core if we're wanting a lightening of a tattoo or something like that. If you have textural irregularities, then certainly the core can be beneficial to improve that. However, just using the PicoWay itself and getting rid of the tattoo, often some textural irregularities or scarring will tend to improve like at the same time. So sometimes you find that you're sort of planning on doing subsequently the CO2 and find that you don't need to do it. Some people do like to do it all at the same time to reduce any chances of blistering and things like that. However, I've not really tended to do that so much, and I find that most people would like to see how they go with the PicoWay first of all, without sort of going to more lasers if they can avoid it.
Dr. Dingley, thank you so much for your time this evening. That's all the questions. We'd like to thank all attendees. Our next webinar will be on Monday, the 11th of May at 7 p.m. Australian Eastern Standard Time. The webinar will be with Neil Osborne from the Sales Catalyst. It'll be a business-related topic focusing on your clients' booking, buying and spending behaviours. On behalf of everyone at Candela, have a good evening. Thank you very much.